Hello, my name is Laura Guerra-Cardus. I'm with the Children's Defense Fund testifying in support of House Bill 342. Thank you to all the authors and joint authors who have filed this bill. We're here to express our strong support for children's health care coverage and ask that the legislature take action this year to reverse the troubling and worsening trends that we are seeing in our child uninsured rate. For over 10 years, the Children's Defense Fund has helped families enroll in Medicaid and CHIP in Houston, the Rio Grande Valley, and East Texas. And since the implementation of these monthly income checks, we have seen significant confusion amongst families and providers who can't understand why their children are cycling on and off coverage so regularly. Some of the top issues we've seen in the field include confusion about renewals versus periodic income checks. Families will get a letter, but it's asking for similar things that they just sent in, and they feel like they've already addressed it. Delayed receipt of letters and inadequate time to provide information. Families get 10 days from the day the letter is generated, not the day they receive it. And we have too many families coming into our offices who got a letter past the due date that their paperwork was due. Eligibility system errors. We had one family who had to get a letter from an employer to prove that they no longer worked there when they in fact had never worked there. And then issues with families with fluctuating incomes, like those working seasonal and contracts jobs, have to just keep applying again and again. The implementation of these monthly income checks has increased the number of times eligible children can fall through these kinds of cracks from 1 time a year to up to 5 times a year per child. Recent HHSC data, as you know, shows that 92% of these children lose coverage during these checks are for procedural reasons and not because they're over income. And that has confirmed what we have been seeing, health plans have been seeing, and providers have been experiencing. The data also shows that 50% come back on the program within a year. If you wonder about the other 50%, we know many families that just don't apply again. They take the state at their word and assume that they aren't going to qualify or, are tired of trying, and then rely on the expensive emergency room care. I want to point out that we know that we have, of our roughly 850,000 uninsured children in Texas, 350,000 of them are eligible but not enrolled for Medicaid and CHIP. So our problem is actually not getting more of the eligible children on the program, less so than finding the few whose income has risen that need to be moved off the program. And for that group, I just want to note that they would be moved to the appropriate program just a few months later. It's not a desire to keep those kids who no longer qualify on forever. It's just allowing them to keep it for a few extra months to reduce this hassle for so many others, and they can just move on to the other program, which has a similar match rate, and so our savings isn't that much for moving them from one to another. Okay. I have so much more, but I know that we're out of time. Thank you.
Sorry. And I tell people, look, we do the 3 minutes. If members have questions, and you're also, you have a representative probably that you also can talk to, and you can talk to us as well afterwards. So, members, any other questions? Yeah, absolutely. Representative Clark.
Has anybody considered, so the parent shows up with the child to go to the health care check and say, we're sorry you're no longer covered? Has anybody thought that perhaps what you do is when you show up for the check that the paperwork be done there? I've never gone to a medical office and they not say, fill out this and sign this and turn this in. And then you go ahead and have your checkup, turn in the paperwork, and then you get qualified. But is that too simple?
Yeah, if you get, so many of these families have to re-enroll again, and we have 3 months of retroactive coverage, which is why I think the fact that the fiscal note is so low points to the fact that these are largely eligible children cycling on and off, because when they come back on, we're having to back pay. Some families, though, won't use the care they need because they don't necessarily know that. So then you have those delays in care. In a clinic, I think it's convincing the family that they won't end up with a bill if the paperwork has some other error or issue to it. The clinics we've talked to say that usually families just prefer to reschedule and go figure out what's going on. And a health center in Houston said that this is really problematic for vaccines, and that kids tend to drop off in the early part of year when they turn 1, which is the measles, mumps, rubella. So they really see it as a public health issue as well.
It just seems like we have 90% that could or should be qualified. Go ahead and see them, seal the crack there and move forward.
Yeah, I think, we've been doing this for a long time, and the best practice is just, if we believe that children should be getting health care coverage and we want to do the most we can to fulfill that goal, 12-month coverage is just the way to do it. And the slight cost of these little imperfections is just not worth the squeeze for all the hassle we have, not only for families, but we've heard today that we can't implement quality-based payment initiatives. So that's our way to reduce the cost of care by not paying for services, but paying for quality. The best way to do that is to make sure a child has a stable medical home with a stable provider who knows them. So we're missing out on that. We're missing out on our ability to track data in Medicaid managed care. So the Dallas Morning News reports series of when kids didn't get access to Medicaid managed care. Well, we want to look at the data to understand the quality in Medicaid managed care. And we're not getting the full picture, because any child that doesn't remain on coverage for a full 12 months, that data is not calculated in. So and then of course you have the local communities absorbing the cost of the uncompensated care, and we know that kids seek the emergency room when they're not covered much more often. Thank you.
Members, any other questions for the witness? Yes, Representative Mesa.
You attached this page.
Oh, yes. Points I didn't get to.
About the uninsured rate of children under the age of 19 in Texas by congressional district.
Yes,
The congressional district I live in is the worst in the state of Texas, CD 33. So I'm hoping that what we're working on or talking about today will help address that terrible problem that we have of the high uninsured rate.
Absolutely. So our national uninsured rate is at 5%. Texas is at 10.7%. And it had been improving for 10 years, and then we turned course, and it started to become worse between 2016 and 2017. National trends show that our uninsured rate will continue to rise without action. And that is a big problem for all communities, but I had included that to actually point out that it is especially problematic for rural communities. Torch, y'all all know Torch, site uncompensated care is one of the major factors for rural hospital closures. 19 of the 70 that have closed in the country are right here in Texas. And while our uninsured rate in Texas is 10.7. When you look at rural Texas communities, they range from 11% to 15.3%. So they're even higher than Texas's average, and they're at times 3 times the national average. So it's a big problem for rural hospitals to let our uninsured rate continue to rise for kids.
Thank you.
Do you have any data, because other states have done this, on continuous care in terms of, because we talk about decreasing the amount of ER coverage?
Yes. Yes. I can get you information, but there's data that shows, compares children with continuous coverage versus non-continuous coverage, and the non-continuous group has much higher use of emergency rooms and much higher cost per emergency room visit.
I really would like to see that, because that is something, that's important and you would expect, but honestly it is inconsistent with what I've seen in a lot of the Medicaid expansion states, that has not been the case when you compare the ER visits that you would assume that it would, but it hasn't in some places.
Yeah.
And I'm not saying it's not a good idea from a policy standpoint. I'm really not. I think there's, when we make it just difficult to make it difficult, that's not good for anybody. Yeah, I'd love to see that data, but I just think there's
the Medicaid expansion numbers. There's a lot more factors, like a lot more people who haven't had insurance for a long time and are learning to use the system. And I know there's some initial costs, but then the trends later on. But I'm very happy to follow up on that.
Okay, thank you. Members, any other questions? Thank you for your testimony.
Thank you.